So let's start talking about alterations in cardiac function. We did blood last week, and there is going to be a certain amount of overlap between blood vessels and cardiac function, especially in regards to that left side of the heart, right side of the heart thing that we did on the worksheet last week. That's going to play into this quite a bit. So let's start with coronary heart disease or coronary artery disease. This means that there's some amount of occlusion in the coronary arteries. So quick review here. This is your left coronary artery, and that branches into LAD, left anterior descending, also known as anterior interventricular artery. And then the right coronary artery is going to come around to the posterior portion of the heart and do a posterior interventricular artery in the posterior surface of the heart. So if somebody has some amount of occlusion, some kind of plaque buildup, some kind of atherosclerotic plaque perhaps, those coronary arteries are no longer going to be able to deliver enough oxygenated blood to the myocardium. And that can lead to problems with delivery of oxygen and nutrients to cells that can lead to, in some cases, cell death. Myocardial infarction means those cells are dying. Just having low delivery leads to pain in the chest, angina pectoris. It can lead to dysrhythmias, heart failure, and sudden cardiac death. We do worry quite a bit about coronary heart disease. We talked briefly about atherosclerotic plaque last week, but we'll talk about it more today. Atherosclerosis is a very big risk factor for coronary artery disease. And that means that a plaque is narrowing the arterial lumen. We do worry about coronary vasospasm and in addition to thrombus formation and endothelial cell dysfunction. So let's look at the mechanisms that are leading to this atherosclerosis. Let's talk about LDL and HDL lipoproteins. You have high density lipoproteins that are going to transport cholesterol from peripheral tissue back to the liver. HDL is the good one. It's going to clear away atheromatous plaque. So again, when we're measuring somebody's cholesterol, we're not measuring fat. We're not actually measuring literally the cholesterol. We're measuring these proteins that carry the fat through the bloodstream. Oil and water do not mix very well, so we need a mechanism to transport the lipids, and these lipoproteins are the things that transport these lipids. So the high-density lipoproteins are very effective at clearing away fat that's been improperly deposited into your blood vessels. Low-density lipoproteins are going to be the opposite. Low-density lipoproteins also carry lipids, but instead of carrying them from peripheral tissue back to the liver, they carry fats to peripheral tissue. So there's a little metaphor I have for this. So you're at a job site. We're gonna be on a job site where we're building something. And there's two workers. There's the low density and there's the high density lipoprotein. Now the low density lipoprotein is a really bad worker. He's gonna get a whole wheelbarrow worth of building materials, but he's really, really lazy. He's just gonna dump them off somewhere, like in the path to where they're actually building stuff. And he's just going to dump them out and he's going to go take a smoke break like a complete jerk. The high density lipoprotein is a really, really effective worker. He's great. Not only is he going to do his job of carrying the materials to the job site and the build site, he's going to pick up all of the bricks that were dumped by this jerk and he's going to cart them off to where they belong. So if somebody's got an imbalance of these and he's got too many bad workers and not enough good workers, you are going to be dumping more lipids into your cardiovascular system than you are taking them to places like the liver or into cells that need fats properly. And that's going to be part of our buildup of atherosclerotic plaque. So let's say you have elevated LDL, you got a bunch of bad workers, and they're dropping off a bunch of fat into your cardiovascular endothelium. The next step in this is my good friend monocytes are going to show up. So you know what monocytes are. They are macrophages. They are big eaters. They're here as a cleanup crew. They're coming in and they're going to try to take this fat that the LDL left behind and clean it up. And what they're trying to do, what they want to do, is remove it, right? I think I promised you a possum in a bakery last week. So let's look for my possum in a bakery. I've been having some upload issues with this morning, by the way. There's a reason it's delayed, and it's not that I'm just slacking off here. So possum in bakery. So here's the story. This possum, whoops, did not mean to do that. This possum broke into a bakery at night when nobody was around, and as a possum would do, it went and ate all the pastries. But in eating all of the pastries, it completely filled its belly and it got too fat to move. So the bakery owners got there first thing in the morning and they just see this possum just sitting here, just like, I can't move, I can't go anywhere. So it was trapped there. Luckily they didn't hurt it. I regret nothing. Possum presumably was pretty happy with its haul. I hope it didn't injure its stomach or anything like that. I think everybody was fine in this scenario. This fat, chubby possum right here is like a metaphor for our macrophages in coronary heart disease. So it broke into the bakery, it ate all of the fat sweets, and it got too fat to move. Once that macrophage consumes too many lipids in the lining of the blood vessel, it gets too fat to move. Literally, it becomes part of the plaque. So just like that possum couldn't get out of the store, your macrophages become foam cells and they can't get out of the plaque. And they actually end up building into the plaque and the blockage. So let's look at that possum one more time because it's just adorable. It's so cute though. It's so cute. So I do find these cells adorable, except that the implications here are that you're going to have a massive plaque buildup. So some atherosclerotic plaques are going to be stable. They're going to have a lot of collagen and fibrin that helps stabilize the cap of the plaque. And if it's stable, that means it's unlikely to break off and go somewhere. So that's a good thing to have. I mean, if you have to have atherosclerosis, you want that atherosclerosis to have a stable plaque. A vulnerable plaque is going to have a lot of lipids in it. It's a large lipid core. It's going to have a thin cap and there's going to be high shear stress. So maybe your blood pressure is really high, maybe the velocity of your blood's going very fast, and it's just going to shear off the top of this lesion and you're going to throw a clot. So we do worry quite a bit about clot formation, not just the buildup of plaque within the artery. We worry about both because even a stable plaque can eventually occlude an artery and lead to ischemia. But throwing a clot means we're also in danger of something happening downstream. So typically this is a multi-decade process. Foam cells happen early on, along with a fatty streak, an intermediate lesion, then we call it an atheroma. We see that fatty buildup, a fibrous plaque, and then we worry about that rupture phase. So again, this typically is decades-long process. I want to remind you guys that the last time we went to the coroner's office in fall 2018, we saw a 27-year-old woman with 75% occluded right and left coronary arteries. So she had this going on at the age of 27. So yeah, there's a genetic component. There's also a nutritional component. It does depend on how much fat you are consuming, how much fat can be deposited into your blood vessel walls. That having been said, not all fat is created equal and not all fat is evil. Now you already know what happens with ischemia because we've already seen the physiology of ischemia and hypoxia and how that can cause cell death. In the case of cardiomyocytes, we know a couple of things special are going on with cardiomyocytes. We know that adult muscle cells are not capable of mitosis. So once you have ischemia to these cells and necrosis has occurred, you're not getting new cardiomyocytes out of that. You're getting scar tissue. And that's going to decrease the ability of your heart wall to actually contract, and that's going to decrease your ability to eject blood. Okay, so first, if you have a partial occlusion of a coronary artery, the first thing is going to be angina pectoris. Now, no permanent myocardial damage is occurring just because somebody has chest or even arm pain. It feels like burning, crushing, squeezing, choking, and sometimes that pain refers away from that mediastinal region. Let's see what else. Elsewhere on the spectrum here is acute coronary syndrome. So chest pain more severe, longer lasting than typical angina, and it usually relates to plaque rupturing and acute thrombus development. If the occlusion is complete, at that point it is a myocardial infarction. And on your ECG, remember you've got a P wave, a QRS complex, and a T wave. Between the end of the QRS and the beginning of the T wave, we call that the ST segment. So a common biomarker to diagnose a myocardial infarction is an elevated ST segment. Do I have a picture of that? I do not. Let's look at an elevated ST segment. And we frequently refer to that as a STEMI. So PQRS, that's super, super elevated. That's crazy. Remember what a normal is going to look like. Normal is going to look more like this. PQRST, PQRST. If the segment from here to here is elevated, we call that a STEMI. Post-infarct, you will see some necrosis. So I believe this is coagulative necrosis, if I recall correctly. Now, your more normal-looking muscle cells are out here. Compare that to this sort of shiny, fatty region over here. This is no longer functional, contracting muscle tissue. Now, this person is dead, and they also have hypertrophy, by the way, ventricular hypertrophy. That's not the width that's supposed to be. There's our STEMI. I knew I had one. Okay. This person has said, but myocardial infarction does not always lead to death. There could be a smaller area of heart that is destroyed in this, for example. The rest of the cardiomyocytes may still be able to contract and keep a person alive, but the health of the heart has decreased. Its capabilities have decreased. So an elevated ST segment, or also sometimes an inverted T wave, are typical myocardial infarction patterns that can be seen on the ECG. As lab values go, depending on how long it's been since the myocardial infarction began, myoglobin is a protein found in cardiac muscle cells. That's going to peak first. And then we're going to see a peak in troponin and CKMB. And I think we do talk about CKMB a little bit later. Let's see. CKMB, cardiac marker, diagnosis myocardial infection. It's the bound combination of some enzymes, including phosphocreatine kinase is one of them. But I do think we talk about CKMB later. Now, if somebody has a history of myocardial infection, or perhaps they have some chronic ischemia that is progressive and slowly killing off heart tissue, they can develop heart failure as a result of coronary artery disease. The prognosis for this is poor. Once somebody has heart failure, it's downhill. Now, we will talk about heart failure in detail, and I just want to start by saying with heart failure, it could be days, weeks, months, or years as heart failure progresses, and we'll see how that occurs later. Continuing on with some other things that can happen with the heart, endocardial and valvular diseases. So these would be Issues related to the endocardium. Remember that the valves are derived from the skeleton of the heart, the fibrous skeleton, but also lined with endocardium. So if somebody has, for example, endocarditis, they may also experience inflammation and thus scarring of the valves as well. Calcification can happen. There can also be congenital malformations that lead to problems with valves. And I want to show you something with stenosis. If a valve is problematic, when it is closed, it is not completely closed. And when it is open, it is not completely open. So this causes problems twice. Remember the function of a valve. A valve closes, and that means that blood cannot go backwards through the heart. If you have not aortic valve stenosis, sorry. If you have valvular stenosis, that means that when a chamber contracts, blood can flow backwards. And that's a problem. It means it's inefficient at going forward. It also means when a valve is open, it's inefficient a second time because not enough blood is going to be able to go through it. So stenosis is problematic twice. Stenosis means the failure of the valve to open completely, and that does mean the heart has to work harder to move blood forward. It also means regurgitation is going to occur, which also results in extra work for the heart. And what happens when you work a muscle more? What happens to that muscle? It's going to hypertrophy, and then you're going to end up with cardiomegaly. So murmurs can commonly be found if there is a valvular disorder. Mitral stenosis is relatively common. Let's talk about this right here, chronic pulmonary hypertension because of mitral stenosis. Let's see something real quick. Okay. So go back to that worksheet that we did last week and look at the right side of the heart and the left side of the heart and the things that lead to the right side of the heart and away from the right side of the heart and the things that lead to the left side of the heart and away from the left side of the heart. Now, the left side of the heart, the lungs are going to the left side of the heart, and that aorta is going to the body away from the left side of the heart. So if you have a problem moving blood forward through the left side of the heart, that means there may be backup into the lungs. Okay, mitral stenosis, mitral regurgitation. You're going to see these phrases leading to left-sided heart failure, leading to right-sided heart failure. We'll talk about right versus left-sided heart failure in just a minute. Prolapse is not the same as stenosis. Prolapse means there's a ballooning. It's not that it's more solid, it's that it's weaker and it balloons. It can be asymptomatic, or there can be some mild issues, dizziness, fatigue, chest pain, depression, and anxiety actually goes along with this. That's a mitral valve prolapse. That's the part of the valve that's ballooning up. And again, it's problematic twice because blood's going to regurgitate and it's going to be harder to move it forward. We've talked about stenosis, aortic stenosis. A beta hemolytic streptococci can infect the endocardium, and that can lead to rheumatic heart disease, and that rheumatic fever can also lead to eventually heart failure. So again, this is a disease of the endocardium. In addition to the endocardium being vulnerable to infection, the myocardium can also experience infection. Leukocyte infiltration into the myocardium is myocarditis, And that's probably because a microbe got in, or maybe it's autoimmune or viral. There are multiple kinds of cardiomyopathy. There's not just one kind of cardiomyopathy. We've already talked about hypertrophy of the ventricles a little bit. If your heart has to work harder for any reason, maybe a valve defect, for example, that cardiac muscle will work really hard to push blood forward and it will grow. And that actually decreases the size of the ventricle. So the wall becomes larger, but the lumen space becomes smaller. And that means your cardiac output decreases. And that means your heart has to work even harder to push out the same amount of blood. Another kind of cardiomyopathy is a dilated cardiomyopathy. And that's kind of what we've been seeing. Myocarditis can lead to a flabby or patchy necrotic lesion of part of the heart wall. And that would cause a weakness of the heart wall that's going to dilate out, sort of like abstractly like an aneurysm. It bulges out and it's weaker at that point. We call that a dilated cardiomyopathy. And that dilated cardiomyopathy is, again, going to be worse at ejecting that blood, even if the lumen size is large. There's also restrictive cardiomyopathy, and that just means it's firm. It doesn't have the extensibility and the elasticity that the heart wall should have, and that again means insufficient pumping is going to happen. The pericardium can also become diseased because of infection or trauma or metabolic problems or neoplasia. Very commonly, fluid can make it out into the pericardial cavity. So that fluid can be serous, and that's sort of the normal fluid. Or we could have chyle from the lymphatic system, or we can have blood in that space. Cardiac tamponade is when fluid fills the pericardium to such an extent that the heart can no longer relax enough to fill with blood. Your end diastolic volume will be decreased. And that means your stroke volume will be decreased, which means your cardiac output will be decreased. We already saw this a little bit in terms of cardiogenic shock. The good news here is if we remove this fluid, we can restore the heart's ability to pump. Only if we remove that fluid in time. Because aside from that, you're going to have cardiogenic shock. And again, you're also going to have backup of blood on either side. This is the entire heart. So you're going to have backup in the lungs and backup of blood in the body. Acute pericarditis, usually we presume a viral etiology. Chronic pericarditis, when you have chronic inflammation of the pericardium, you're going to worry about the heart sticking to the mediastinum. I actually saw this with my cadaver. She'd had multiple bypass surgeries, and they'd had to open that pericardial sac multiple times, effectively destroying the pericardium. And the anterior surface of my cadaver's heart was mostly scar tissue. She definitely had adhesive mediastinopericarditis. So again, the mediastinum or mediastinum, depending on who you ask, being that midline cavity where the heart and structure superior to the heart reside. Now, because of embryology, for most of these, this is going to be about embryology, and again, our embryology lecture is not till later. We're going to have a number of heart defects that people can be born with, and they're going to be categorized as cyanotic or acyanotic. Do they make you turn blue, or is your oxygen insufficiency so bad that you are turning blue? Or is it a minor oxygen insufficiency? And let's look at what makes them do each of these things. So a relatively common heart defect is the atrial septal defect. Often people say the phrase, oh, I was born with a hole in my heart. And often what they mean by I was born with a hole in the heart, they mean a hole between the atria, most commonly, or a hole between the ventricles. They don't mean a hole in the heart wall. That means they're like literally gushing blood into their mediastinum. Usually this is what you mean by you have a hole in the heart. It's in here somewhere. So the atrial septal defect is relatively common. And again, it's because of embryology. I will have a slide in our embryology lecture for why that is. Remember that before you're born, in fetal circulation, you're supposed to have a connection between the right atrium and the left atrium. An atrial septal defect just means that moment when you're born and you take your first breath, instead of that hole closing up, it just stays open. That's why it's the most common one, is because honestly, it's supposed to be there in fetal development. It's just supposed to close the moment you're born and you take a first breath and blood comes back from your lungs. So this can be variable in seriousness, but it is an acyanotic defect. You're just going to have mixing of oxygenated and deoxygenated blood. As long as some oxygen is making it to your tissues, it's survivable. As I understand it, this can be surgically corrected. We might even wait a while to surgically correct this. Let the heart grow a little bit, let the baby grow large enough that open heart surgery is less of a risk. Ventricular septal defect means that that septum between the left and right ventricle has a space in it. Now this is different embryologically. You were never supposed to have a space there. This is going to be more of an issue of the cells that proliferated there during embryology failing to do so. And this one's actually going to go with a lot of other congenital disorders. Somebody who maybe has a cleft palate may also have a ventricular septal defect. And again, we'll describe more of that during our embryology lecture. Again, you just have mixing of oxygenated and deoxygenated blood. As long as some oxygen is making it to tissues, that'll be an acyanotic defect. Now, another embryology thing is another shunt that's normal for embryology is to have a ductus arteriosus. A connection between the pulmonary trunk and the aorta is also part of fetal circulation, meant to bypass pulmonary circulation and mix oxygenated and deoxygenated tissue from the blood from the placenta. Now, a patent ductus arteriosus, just like our patent foramen ovale, means that it just failed to close when you were born. That's all. And once again, it's an acyanotic shunt. In an adult, you no longer have a ductus arteriosus, you have a ligamentum arteriosum here. So that aorta is actually adhered to the pulmonary trunk via a ligament in a normal adult person, but it's a ligament, not a tunnel in an adult. This is kind of a weird illustration for coarctation of the aorta. Coarctation just means thinning, and I think I might look for a different image for you for coarctation of the aorta. Coarctation. We always illustrate it as this like sudden short narrowing, and it can be just in one place. A coarctation can be a narrowing in just one location. Let's see if I can find some radiology though. It can also be a lengthy narrowing of the aorta. It could be that much of the aorta is narrowed. Actually, that's a pretty good. I don't know. We'll tolerate it. We'll just deal with it. So this is a narrowing of the aorta, and remember that aorta is the biggest artery you have. It's sending oxygenated blood literally everywhere to your entire system, right? That's what it's there to do. This just means you're going to have a weaker pulse in the extremities. There's no mixing of oxygenated and deoxygenated, but just less blood and weaker flow is getting there. And that is going to still cause some problems and be an issue. Now we get into some fun stuff. Tetralogy of Fallot. Just like Tetris, tetra means four, right? That in the game of Tetris, all of those blocks are composed of four squares. So tetralogy of Fallot means there's 4 things wrong with you. You've got a ventricular septal defect. You've got pulmonary stenosis. So you've got stenosis of that pulmonic valve right there. You've got an overriding aorta. So instead of that aorta, that aortic valve being just exclusively associated with that left ventricle, that aorta is overriding the ventricular septal defect. So every time your ventricles contract, you're having blood push into both of these at the same time, probably more the aorta than the pulmonary trunk. So that creates a unique problem. That also leads to right ventricular hypertrophy. So this is the result right here, although it is considered one of the 4 conditions of the tetralogy. Now it's harder to push blood through that pulmonary stenosis, so more of it goes through that aorta. So the right ventricle has to work harder if it's going to get any blood in here, so it becomes hypertrophic. This is a cyanotic defect. We've finally managed to get enough wrong that the blood flow that is being pushed forward is inadequately oxygenated and there's an inadequate quantity being pushed forward from the heart. Usually at this point, people ask me about survivability. I don't really know the survival rates. Let's find out about survival rates so that I stop doing this. Tetralogy, low survival. So actual survival rate's pretty high, 94% at 1 year and 91% at 5 years. It looks like it requires quite a bit of medical intervention. As I understand it, there's a sequence of surgeries that may be necessary, and like that search indicated, a variety of medical interventions for this. Okay, more embryology here. We'll talk about this embryology week 6, I believe, how your aorta and your pulmonary trunk initially were one blood vessel, and then you actually developed a septum between them, and they differentiated. In transposition of the great vessels, you had the trunk, they separated, they went in the opposite direction they should have gone. So now the right side of your heart leads to your body, and the left side of your heart leads to your lungs. Now, the right side of your heart is still receiving from your body, but it's going directly back to the body. The left side of your heart is still receiving from your lungs, but it's going to your lungs. So instead of having a complete circuit that leads to blood oxygenating and coming back to the heart and leading to the body, these circuits are independent of each other. And that means you are never oxygenating your blood. All right, so here's the weird thing. So definitely a cyanotic thing. It should be incompatible with life. But remember that during fetal development, you have a foramen ovale right here. If you have transposition of the great vessels, but you also have an atrial septal defect that mixes oxygenated and deoxygenated blood, you actually have a better chance of life if you have an atrial septal defect, if you also have a transposition of great vessels. So that's pretty crazy. Let that sink in for a second. Now, same embryology going on here. You had one trunk for the aorta and the pulmonary trunk that developed a septum. In Truncus Arteriosus, it just means that septum failed to develop. That's all. So this is a cyanotic defect. This is problematic enough. This is going to go with a ventricular septal defect. You just have one opening for both ventricles. This is problematic. And that's it for our congenital heart defects. I think I'm going to make this part 3 and stop here. before moving on to heart failure and dysrhythmias. We're almost wrapping it up here. We're finished.